So this is welcome to the 14th Uromet, and this is a third mock viva. Already we had one in stone and infection, and the last time we had the second Uromet. Now that we are moving to the third one. Already we have selected the 6 candidates. So plan is as usual. First, we'll start with Manjula sir. If Suren sir joined, then the second scenario goes to Suren sir, then back to the Manjula sir. So each candidates have to answer for 10 minutes. Trina will count the time and let us know. Trina also include, there may be some distraction time, so give some discount for that. Then we will discuss, after the 10 minutes, we will discuss the scenario, or the examiner will give the feedback and give his expected answer. Then we will discuss that. Then we move to the next scenario. So welcome our examiners and our colleagues. And anything else to say in the preliminaries? Trina, you want to say anything else?
Yeah. Now I know usually at 10 minutes we are supposed to remind. If I give a reminder at 5 minutes, will that disturb this thing, or that will be artificial?
That will disturb.
That will disturb.
Yeah, you might raise your hands up at 10 minutes, so then we can coordinate.
Yeah, so that's right.
In the Zoom, you can send a signal.
All right.
Okay, Lina.
All right.
Trina, each candidate will get 20 minutes, no?
10 minutes, sir.
10 minutes. Okay.
10 minutes for the viva.
Yeah.
So you only
5 minutes for the feedback and
you are only you're only reminding at the end of the session, no?
Yes,
Yes,
sir. 10 minutes. Maybe you can put a hand sign at 8 minutes, Lina, isn't it?
Yes, sir.
Okay.
Just see whether you can notice this. I'll just.
Okay, anyway, we will see. Right. Yeah. So time is flying, and I think Trina, you want to invite Dr. Taha first, or?
Yeah, I will do that. So, welcome everyone once again to Uromet 14. So to start off the first viva, Dr. Manjula Vijayavardhana will start it off with Dr. Taha. So over to you, Manjula sir, and the time starts now.
Okay, good evening.
Good evening, sir.
Are you able to see my screen?
Not yet, sir.
How about now?
No, sir.
The first case is on the screen.
Screen is still not been shared, sir.
Huh?
Share the screen, sir. Go to the share button and share the screen.
Okay, how about now?
Starting. Now it's starting, sir. I think I would be.
Okay,
yeah,
sir. We can.
All right, sir. Now we can start. Okay.
Yeah, press that button, sir.
Okay. Now do you see my? Yeah, you have seen my step case scenario, no?
All right. Sir.
Yes.
Now
Sir.
it's okay.
Only thing the thing is okay.
Now it's perfect, sir. Everything is perfect.
Right, Taha? Right.
Yes,
okay.
sir.
So Taha, you read this.
Yeah, 50-year-old lady was referred by A&E physician with sudden onset of watery discharge from vagina. She underwent total abdominal hysterectomy for menorrhagia 10 days ago. She is a known type 2 diabetes and has past history of endometriosis. Histopathology of TAH specimen, no malignancy.
Okay. So Taha, what are the possible causes of this symptom?
Okay, so I mean, it's a 50-year-old
A lady
patient.
has come to the A&E. Yeah.
Yeah,
She's
50-year-old
leaking.
patient after TAH leaking from the vagina, my main worry is to rule out any fistula. But there are other causes such as infection and vaginitis. Yeah, those are the main causes. But my main worry is rule out the vesicovaginal or uretrovaginal fistula, sir.
So what are these, the total varied spectrum of fistulae you might get in this patient? You mentioned vesicovaginal fistula. What are the others?
It can be uretrovaginal fistula, vesicovaginal fistula, and very rarely uretrovaginal fistula. But it depends on the duration as well as when the watery discharge occurs from the time of the operation, sir.
It also could be a combined fistula. Okay, so what is most likely in this patient?
Most likely would be vesicovaginal fistula, because it's like a patient with diabetes mellitus, endometriosis, past history of endometriosis. So there may be possibility of addition as well as postoperative infection as well. So I strongly suspect whether there is possibility of vesicovaginal fistula, sir.
Given only the history, how would you exclude ureterovaginal fistula from the symptoms alone?
So probably I can ask whether the post-operatively she had a catheter. So when there was a catheter, which is little unlikely to have discharge if it is an uretrovaginal fistula, but sorry, it can, it is very unlikely to have a discharge if it is a vesicovaginal fistula, but that not exclude the presence of vesicovaginal fistula. Other thing is any so that's the only thing I can think about, sir, that with the catheter, if there's discharge.
From the history of that the operation took place transvaginally, can you exclude a uretrovaginal fistula? Because there was no any vaginal manipulation.
I cannot exclude, but it is very unlikely to cause urethral fistula.
Okay, fine. Right. So it's an abdominal approach. So very unlikely to be a urethral. Right.
Yes, sir.
So in the given history, what do you think are the precipitating factors for a VVF in this patient?
Past history of endometriosis and diabetes mellitus, and possibly age. I mean, elder age. There may be lack of immunity. That may be another less precipitating factors. From the
patient
history,
is not that old. Patient is not that old. Right.
Okay.
Okay, it could be infection. Infection at the time of the operation.
Yes, sir.
Okay. So do you know any other surgical procedures that can give rise to a vesicovaginal fistula? Apart from this patient, generally?
Generally, even lower segment as a cesarean section, and the TURBT, if it is a posterior wall muscle invasive or tumor, deep resection can cause vesicovaginal fistula. And
any gynecological operation? Apart from the abdominal hysterectomy?
myomectomies and sometimes anterior repairs.
Okay, vaginal operations, yes. Okay, so it could be any anti-incontinence operations or pelvic organ prolapse surgery for the gynae. Urological, of course, if you are using energy devices in the bladder like laser or electrocautery.
Yes, sir.
So other than surgical causes, are there any other etiological causes for vesicovaginal fistula you know
So it can be long-standing malignancies, even with bladder malignancies, cervical malignancies, or endometrial malignancies. They erode into the adjacent organ, invasion or erosion, so they can cause vesicovaginal fistula. And
what is the commonest cause of
pelvic radiotherapy?
fine. What is the commonest cause in the African subcontinent for vesicovaginal fistulae? It's not an operation.
I'm not sure about that, sir.
It's the prolonged labor. It's all labor-related fistulae.
Okay, sir.
Okay. So can you tell something about the pathogenesis of vesicovaginal fistulae? How would it form? Take the example of the patient. What is the pathogenesis?
So during TH for endometriosis, there would be an addition. So there will be, during the operation, there may be ischemia to the tissue plane. So postoperatively, with the ischemia, they can necrose, and then they form a vesicovaginal fistula. So ischemia, necrosis, and then fistula formation would be the.
Okay. I have listed, a lot you can select depending on the index patient. You can select which one would have been operating. So as you said, direct injury, ischemia may have contributed. Okay. So how are you going to evaluate this patient?
First of all, I would like to assess the patient whether she is having any severe infection at the moment. So if that's the case, I will assess the patient according to adult life support protocol, and then I will stabilize the patient, make IV cannula, IV fluids, and sample for blood culture, urine culture, and the vaginal discharge for culture, and then I will start some antibiotic to stabilize the patient. And if she's in pain, I will.
Patient is otherwise very well.
Okay, so then
apart from the leak, the patient is well.
I would like to go through the operative notes where I would say I would see was there any difficulty in during the operation, any additions, any blood loss, and then whether they suspected a bladder injury during the operation. If so, whether they have identified any injuries, whether they try to suture the bladder. Then post-operatively, whether there's any features of infection or hematoma formation, and I would assess in the history whether there's any other history suggestive of immune suppression and pelvic radiotherapy in the past for any other reasons. And then on examination with the informed consent and chaperone, I would like to examine the general features like tachycardia, temperature, and then abdominal examination, whether I can see loin or abdominal tenderness. And then I will do a genital as well as speculum examination, whether I can see any discharge of demonstrable discharge, or else any content of the discharge.
Okay, so you are going to do the sim speculum. Yeah. How about any further testing?
Yes, I mean, I can. Ideally, basically.
Yeah, apart from the blood and urine.
Start with initial imaging, which is like ultrasound scan of the non-visible and easily available. Whether I can look for any hydronephrosis, hydroator, or in the or contralateral, one side or bilaterally, and then is there any pelvic collection, which will lead me to a differential diagnosis. And then if the patient is having a severe discharge, I may need to insert a catheter, and then I may do a 3-pair test or vaginal 3-swab test.
The ultrasound scan revealed mild fullness in the right kidney, small pelvic collection. There is no ascites.
Okay, sir. So this with this case, I could not exclude whether it is a uretrovaginal or vesicovaginal fistula. So I need further testing. Probably the basic, the ideal testing would be CT urogram or CT IVU with need of a cystogram if the patient is not contraindicated, such as the abnormal renal function abnormal, not allergic to contrast studies.
Okay, so let's go ahead with the contrast enhanced.
Time's up for
So
that.
Taha, you can comment on the CT.
So, Sirina's time is up. Sir, do you want to ask the rest of the question in some other candidate, or you want to give the feedback to Taha, sir? I know the time is not adequate.
Yes.
There are more.
No, I will. I will move on to a different topic because we have plenty of topics today.
Okay, sir.
So candidate came only up to diagnosis.
Yeah. So give the feedback to Taha, sir.
Yeah. So Taha was quite conversant with the subject. He was giving my the expected line of thought. He was gradually building it up. So I would say he's quite all right up to that point. Only sorry we could not go ahead for the management.
So the question, sir. But so CT, so seem to be a uretrovaginal fistula, isn't it, sir?
Yeah. No, so, this is vesicovaginal still.
Okay,
Yeah, it is a it's a sagittal view. So it's the connection between bladder and vagina.
Right. What are the further questions that you are planning to ask? Type of repair and things, is it?
Yeah, I was trying to ask for what is the timing, approach, and basic principles of a fistula repair, and any evidence.
Yeah, important things are more marks are given for that discussion. Yes. So how we are going to open and when now we are going to do it surgery. So candidates are spending more time in history and assessment. They are not going to get a higher score. So somehow we have to quickly move fast and move to the important aspect, because the difficult question they give a more score. Decision makings and complexity of the scenario, so they give a more score. So I think in future cases, candidates have to move quickly and move to the important aspect of the questions quickly. Yeah. So Taha, you want to ask any question from sir?
I would like to continue this discussion till management, but I don't know whether time will allow that with other candidates.
Yeah, in the real exam also 10 minutes is fast very quickly. That's the important thing. Yeah. So, and Suren sir is ready, is it?
Selena? Yes, I think what I'll do is I'll show use the camera, the phone, iPhone camera, and I'll show the iPhone camera and use the screen because there's a bit of a technical problem here. But yeah, I'm ready. Yeah.
Okay, Selena, you can introduce the next candidate. Selena.
All right. The next candidate is going to be Dr. Nishantan, and Suren Disilasa is going to be the examiner. So over to you, sir. And your time starts now.
Okay, yeah. What I have is a very common scenario, and I just want to see how this is handled. Basically, this is a post. I'll try and show this to you. This is a post-Turis urine retention. Right? So, 60-year-old male underwent a Turis under spinal anesthesia, and 48 hours later, the urinary catheter was removed, but he could not void urine even after about 6 hours. The question is, what are the common causes of post-Turis urine retention? Yeah.
This patient had a spinal anesthesia as well as the TURIS surgery. So here patient is having retention. So causes might be if the patient might have had an edema at surgical site, urethral edema or inflammation might be the initial cause, common cause, and also there can be associated infection, and there could be clots or remain particles might be there that also might cause retention. And also, if we are not sure, I want to know about the diagnosis, how the bladder outflow obstruction BPH was diagnosed. Is there any other history findings that might suggest neurological causes as well? So these might be my causes.
Okay. So given that scenario, how will you manage this now? Catheter is pulled out, patient is in retention, and how do you deal with this now?
Spinal anesthesia effect also might be there. I can ask the patient.
No. This is 48 hours later.
Okay, sir. So in that case,
patient, so his recovery, he's all packed, ready to go. You pull the catheter out after the operation, he can't pass urine, right? Okay. So the 48 hours later.
Okay. So I can ask about the patient's intake, whether he had adequate fluid intake, and also whether the patient is having a bladder. Then I will confirm the retention, and I can ask the patient to go to the washroom, and if he is not in a pain after giving adequate analgesic, and go to the washroom and open the tap and try to pass urine. If you don't pass the urine, in that case, carefully, I will try to insert a catheter again, sir. And later, after catheterization, I will check whether the patient is having any hematuria or a significant amount of urine is there, particles, those I will assess. And with the oral and I will send the urine for culture VST. And then I can keep the catheter for some more time.
Yes, now you will assume you put the catheter, not much, just a light pink urine came out. There was about 600 cc's of urine. Now, how do you manage this?
So in that case, until the hematuria settles, I will keep the patient. And
no, there isn't much hematuria. There's only a pink color urine.
Okay, in that case, I will keep the catheter for another 1 week duration. Then I will get down the patient again, and I will do the trial without catheter thereafter, sir.
Okay, you do this and patient fails again.
Mm-hmm.
What are your thoughts now?
So in that case, first thing is I want to exclude any other anatomical causes, as well as I want to exclude other functional causes as well. There might be, normally we don't do urodynamics before going for an TURP most of the time. So we might have missed some associated pathologies. So in that case, I want to go for go back to the history and examination, and I will assess first exclude the anatomical causes with the flexible cystoscopy. If that anatomy is normal, then in that case, I will arrange a urodynamics to assess the function of the lower tracts.
What type of anatomical obstruction are you thinking? Now you've gone and done a TURIS and come out. What additional stuff would you gain by looking with a flexible? What are you looking at?
Flexible cystoscopy, of course, whether we have done the adequate resection, there might be some remaining tissues might be obstructing. So whether that this one is adequate, and are there any clots, remaining clots or particles? If those are
Right.
not there, then I will suspect a functional cause in the patients.
Yeah, we'll assume that you did the cystoscopy flexible and there isn't, you think there's adequate, adequate passage there. Now what do you do?
So in that case, I will put the patient on the catheter again, and I will arrange a urodynamics for this patient, sir. Where I want to assess the patient cystometrogram, whether the
Okay.
patient had a functional disease, whether dextrose inability, or patient had a dextrose sphincter dysnergia. Those cases I want to exclude.
Now, is there anything in the history that will suggest that this man has a low detrusor pressure? Is there anything in the clinical scenario given, or do you want to ask more questions to see direct questions to know what are the predictors, in other words, of low detrusor pressure?
So how much volume in blood outflow obstructive patient? Of course, the history we will not give much information, but how frequently he developed, even though the blood outflow obstruction might be there, how frequently he has to. Basically, I will ask about the bladder diary, 3D flow volume chart. Those things I will ask. So in that, whether he had any incontinence, or how much volume he can keep, and whether he, I'm not sure. I couldn't remember.
Yeah. Okay. Is there anything in the history that will point towards a person having a low? Is there any other comorbidity that you're interested in?
If the patient is having any neurological diseases, either peripheral neurological diseases or spinal cord diseases, in that case, he might have low bladder, sorry, not in the upper motor neuron lesion, where we can peripheral nerve disease, diabetes, commonly in our population, diabetes mellitus. They can have autonomic neuropathy, so they can have the poor compliance. Yeah.
Okay, so if he has this issue, how do you think now you put the, there's no, you do the cystometrography, and yes, it confirms that he's got low voiding pressure, right? Now what do you do?
So in that case, I want to I want to reassess the patient history and examination, and in that case, the patient is having a low dextrose activity, no anatomical obstruction. So I want to improve his dextrose activity. For that, we can give, there are pharmacological, there are several sets of managements are available. From pharmacological management to, we can either treat the precipitating factor, as well as there are conservative management, and then there are neuromodulations, pelvic flow neuromodulations are there, so we can treat accordingly.
Yes, so practically, he's there with a catheter, right? You've done all your assessment. There's really nothing reversible there. He's got no diabetes. His peripheral neurological examination is fine. His stools are okay. He's passing stool all right. Now, so how are you going to, what are you going to do with this man?
So if the patient is having low dextrose pressure, upper tracts are normal, I can suggest him to go for a clean self-intermittent catheterization. So otherwise, the patient has to be on a long-term catheter, whichever the feasible for the patient.
Do you know anything about the difference between, is it time up? Is it? Okay.
Yes, sir.
Right. Let me just go back. Yeah. I think this is a very common scenario, and you handled it well, but you were too hesitant. This is a very common problem, isn't it? So you should be a little more confident in how you address the thing. Bang, 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 you should go, right? Common causes of turis, post-turis, clot retention, detrusor failure, or inadequate resection. That's all, right? Bang, you should have said that, with confidence, so that the person, the guy who's examining you knows, okay, this guy knows. When you said all of that, but it was way too sort of the person had to get the information from all what you say. The answer is there, but it should be bang, bang, bang. You're going to be a urologist soon, so that's the level they'll expect. When you ask about predicting low detrusor pressure, again, easy. You have a 350, 400, 500 residual, that tells you your detrusor is weak. That's an important predictor. In the history, diabetes, neuro, you said all of that. Even the low detrusor, large post-point residual, you did say, but again, it wasn't very clear. This is a common problem, simple problem. It must be at your fingertips, right? And yes, if there is low detrusor pressure, you are right. Intermittent self-catheter, or he has to be on a catheter lifelong. That's all. But yeah, so definitely a pass, but you can do much better. Be a little more confident. Don't be intimidated by the exam, and say you had all the facts, you had all the answers, but it was all jumbled up in a lot of unnecessary detail. Right. Good. That's done. Manjula, next. Oh,
Yeah, and
you want to
sometimes
say
they
anything?
will ask, yeah, sometimes they will ask, okay, what are the situation you will do a pre-op CMG before the TURP?
Yeah, that's right.
So, yeah, and there are some evidence saying that routinely doing a CMG before the TURP in all patients, there's no benefit. So we may have to quote that paper. And so this was a very nice and very common scenario. And thank you, sir. Thank you. That was very good. Trina, shall we move to the next candidate?
Yeah. So our next candidate is going to be Dr. Suranga Vijayaratha, and back to Manjula Vijayavadra, sir, to conduct the Viva. Over to you, sir.
Okay, good evening,
Okay,
sir.
do you see my case? Good evening. Suranga, do you see the case?
Yes,
Sir.
yes.
Because
Okay, it's a 50-year-old lady. You can read the passage.
Yes, 50-year-old lady was referred by a GP for worsening of urinary incontinence following the recent culture positive UTI. She is a known patient with type 2 diabetes mellitus. Her BMI is 35. She takes her medication regularly with oxybutynin 12.5 milligram TDS for 5 months ago for urinary incontinence.
Okay. So having known the facts about this patient, what are the questions that are going through your mind?
He has urinary incontinence. It may be precipitated by diabetes mellitus and the UTI as well. So I have to exclude first and the oxybutynin for 2.5 milligram for 5 months. The dosage is adequate or not for this lady, and the BMI is very high. These are my worry, and so it is correct. Actually, it's correct diagnosis or not.
Okay, so these were the responses I was expecting. You said some of those. What is overactive bladder syndrome? What is the ICS definition for this?
Overactive bladder is it's a clinical diagnosis. ICS definition is strong desire to pass urine without abdominal pressure, and it is mostly followed. It's urgency and it's urgency, yes, and the patient presented with the frequency, urgency, and nocturia. These are the three clinical symptoms.
Okay, what are the types of overactive bladder you know of?
Actually, the idiopathic detrusor overactivity and a neurogenic detrusor overactivity. These are the most common types of overactive bladder.
Okay, so there could be wet, dry, phasic, terminal, or idiopathic, or neurological.
Yeah.
Right. So how are you going to evaluate this patient?
So I will evaluate.
The GP did not actually evaluate the patient very well.
Yes, I will review this lady in the functional urology clinic with the presence of incontinent nurse and chaperone, and then I will take the detailed history regarding the my first diagnosis, whether it is a POI and simple urinary incontinence, whether is there any association with stress urinary incontinence or not, and any precipitating factors such as caffeine intake or any fluid in the type of fluid she normally takes, and the history.
How can you quantify? Now this is a very subjective symptom. Yes. How can you quantify the problem the patient is having? By history, how can you quantify?
So I can give actual frequency volume chart to the measure give the objective assessment, and other thing is there are questionnaire like IQ questionnaire for incontinence. This type of objective assessment can be used in this situation.
Okay.
And the pad test as well, but it is according to NICE guideline, the pad test is not recommended nowadays.
Right. So, would you consider flexible cystoscopy in the evaluation of this patient?
If there is any red flag signs like recurrent urinary tract infection, hematuria, I have to do the flexible cystoscopy. I think she has a UTI. I don't know whether it is a recurrent or not, but if it is recurrent, then I have to go for a flexible cystoscopy and assess the lower urinary tract.
Okay. Will you consider any advanced urodynamic studies in this patient as well?
Actually, according to the NICE guidelines, the PO and simple urinary incontinence, I will not go for a urodynamic study, and then the management can be tailored with the clinical diagnosis and the other simple investigations like urine fluid report analysis and the flexible cystoscopy and ultrasound scan. So not in this case, and but while we are moving to the if there is any complication or if there is any indication, actually, if we suspected a PO and PO detrusor overactivity, in that case, I can consider.
Yeah, actually, when the patient was put to the functional NDT, it was decided to go ahead with the urodynamic studies. Why do you think the reason be?
Probably the reason is she has on oxybutynin, so it may be a failure to the treatment medication. That may be the indication, but I think she's on suboptimal treatment dose, and I have to check the compliance as well before moving to.
Yeah, she has been on 6 months of oxybutynin, but she was responding before the infection very well. She is considered a refractory OAB patient. That's the reason.
All right.
Right. So we finally went ahead with advanced urodynamic studies. So what out of the choices you have, what advanced urodynamic study would you do on this patient?
normally the video urodynamics. I will do the video urodynamics to see any dead through pressure and the pelvic cycle and the abdominal pressure.
Which incontinence is best evaluated by video urodynamics?
Actually, it is a stress urinary incontinence because as we are going for the urinary incontinence, I have to exclude other things as well.
For this patient, we did the cystometry only without a urethral pressure profile. So, what is the filling rate would you consider for this patient's urodynamic study? Any restrictions?
I'm not suspecting actually the neurogenic part, so I can go for a 50 ml per minute filling rate. But if there's a neurogenic, we have to go for a lower rate. I think this is normal, so we can go for 50.
So this patient was used a slow filling rate because she is having an overactive bladder. It was considered slow, so it was less than 50 milliliters. Right. Okay, so this is the urodynamic tracing in the filling phase. Can you comment on it if you clearly see it?
This is the urodynamic study. It says EMG and previous cycle and P abdomen and P get in the traces, and I think the zero in the detrusor pressure is zero in is good and the subtraction is good, and I can see that in filling phase the detrusor pressure is slightly elevated, and I can't see the there are minor spikes as well. It's not a big and the filling
Suranga,
phase,
this is for your information. This is the Suranga, for your information. This is the detrusor pressure tracing, and the bottom one is the urine flow. Amount of urine collected in the receptacle.
Right. Okay. In filling phase, the detrusor phase is slightly elevated, and when she void, the detrusor is there's a spike, a very big spike. So I can't see actually the.
No, there is no voiding phase in this one. This is only the filling phase.
Only the filling phase. Then there is a high spikes on the P det. So I think I suspect the detrusor overactivity.
This is clearly a detrusor overactivity, and the patient has leaked in both instances.
Right. Okay.
Right. So, do you have now, this patient is suspected to have refractory OAB. Do you have any definition for refractory OAB?
The overactive bladder is not responding for the pharmacological as well as the conservative management for more than 6 months. So then.
Okay, we'll quickly move on to the management. How would you start managing this patient?
So managing after full assessment, I would start with the first lifestyle changes like reducing BMI because BMI is 35, and controlling the other comorbidities like diabetes, treatment of the urinary tract infection, and then reduce the caffeinated drinks if she is taking, and the pelvic floor muscle training with the dedicated physiotherapist, and then the then after everything, then I have to go for the pharmacotherapies. We can change into the another pharmacotherapy because of the oxybutynin, and then go for a Botox injection.
Time's up.
Like that.
Time's up, sir.
Okay, thank you, sir.
Okay, right. So there are many more questions to come. So I really artificially all sped up. Suranga did 2 fatal mistakes. That is a bit of a problem. Now, Balagobi, how is that situation? Because his interpretation of the UDS curve was inaccurate. Then,
First of all, this is a very excellent scenario, and you have spent a lot of time and nicely made the scenario. You are better than the FRCS examiners. So definitely we have a hope that in future we can run this exam with you.
Yeah, but what would you do if a candidate makes two fatal mistakes?
The Dr. Suranga was answering nicely. So there are some positive about him, that he said about the quality assurance of the urodynamics, like
Yes.
he said about the zeroing.
Zero line.
Yeah, but
Cancellation of the cough. Yes, yes.
Yeah, of course there. As you are telling again, this is a filling phase. So he missed that. And so this is a very easy urodynamics, because easily you can see there are overactivity and there is a leak also. So you have to say that correspond to the feed at high, there is a leak. So this was a very straightforward urodynamics. So we should have not missed that. And again, sir, regarding the initial assessment, he should have told the ICIQ and questionnaire, the bladder diary straight away in the assessment, rather than you prompt
Right.
and
Yes.
it. Of course, he know the answer, but that prompting will reduce the performance. So, but he professionally answering very well, but needs some more practice. This is, of course, we are not routinely doing urodynamics and this area, the urogynecology and neurourology, we are not exposed a lot. So that may be the reason, but it's an excellent scenario, sir.
So I think if I give a feedback to Suranga, he needs to appear for the exam for the second time.
Yeah.
And also he should, be conversant with this UDS tracings, like you look at a ECG. Wherever you get the opportunity, you should look at the UDS tracings. Because then you will realize that the urine, the ura is at the bottom, P det is next, and the two subtracting curves are at the top. So you will not miss it.
Yeah. Thank you, sir.
And they will ask a lot of other questions like what is next, oxybutynin, what is tolterodine, solifenacin, where they act, which receptor they act, what are contraindication, what is mirror background, where is act, what are the side effects, and they will ask a lot about the Botox, so receptors and side effects and things. So they will ask about the different studies.
They'll ask about the EMBARK study, no?
Yes, sir. Impact study and
They'll
addictive
ask
study.
for that.
Yes, sir. Maybe they will ask. Yeah, so if time permits, we will discuss those later, sir. So we will move to the third scenario. Tilina, over to you.
So the third scenario is going to be done by Dr. Suren De Silva, sir, once again, and the candidate is going to be Dr. Nishanta Veerasinghe, sir. Over to you, sir.
Just
Good evening, sir.
Yeah, hello, good evening. I'm sorry I have to show this. Just I'll spell it out for you. Again, common scenarios. A 68-year-old man with poor urine flow, prolonged voiding and frequency with an IPSS score of 21, right? He's on tamsulosin for the past 1 year, and he's not responding and he wants something better. His urine flow rate, Qmax is 6 mLs per second, 6 mLs per second. Prostate is 40 cc's, and he's got a post-void residual of 350 cc's, and his PSA is 2.1. This man comes to you and says, I want something better, doc, can't you fix me with a surgery? The patient is requesting surgical therapy. How would you counsel this patient? What are the important things you're going to tell this guy before you do any surgery on him? Counseling.
Okay. I would like to reevaluate the patient's history examination to exclude whether there is anything that we missing here, like urethral strictures, meatal stenosis, phimosis, or like this thing. And then after excluding those things, I will say him that if it is likely BPH or could be neurogenic underactive bladder. So, so in this case, I will explain to him that the surgical intervention, there are a couple of surgical interventions depending on the availability and surgical expertise. I will explain him the possibility of TURP that is the commonly available in our country, and the its outcomes and the risks.
So you will explain the operation TURP. Okay. Is there anything else you want to tell him?
Anything else?
Yes.
There are other couple of options. So other than TURP.
Okay. You will mention other options.
Other options are.
No, my question is not other options. All right. Yes, there are other options. You have chosen the TURP option or TURIS option. Is there anything else you want to tell a person before you operate on it? Now you are telling him you're going to offer him TURP. All right. Now, is there anything else you want to tell him, or do you just take him to theater and do the operation?
No, so I would explain him the risk of the surgery, the complications.
What do you mean? What are the risks?
The risk of surgery is mainly the bleeding that might require transfusions, and risk of infections, and intraoperative damage to these structures. And post-operatively, he might need a catheter to wear in the, and then there will be irrigations, and the risk of post-operative risk of incontinence less than 1%, risk of erectile dysfunction, and then post-operative sometimes if there is underactive bladder, he might develop retention and later require self-catheterization or long-term catheters in rarely in some cases.
In this guy, yeah, you're right. That's good. Now, in this guy, is there any in the history and the test done? Is there any hint even that this guy may not do well with the operation? With your
yes, yeah, because he is having high PVR, 350 cc, so that is a risk of developing post-operative complications.
Okay.
And he had a high IPSS score, and the duration is more than 1 year.
Okay, right. Now, yes. So this is going into more theory. Now, how would you confirm bladder outlet obstruction?
Clinical and investigation findings. So clinical findings mainly that we can confirm with the clinical history just to make a clue, like the prominent obstructive voiding LUTs. But in confirmation, I need to actually go for pressure flow voiding urodynamics, and voiding uroflowmetry also is cannot exclude underactive bladder versus obstruct.
Yeah. Okay. So in simple terms, you said you're going to do urodynamics. What are you going to expect if the patient is obstructed? What are you going to see, and how are you going to know?
I would on urodynamics, I would see poor flow with high voiding pressures.
Okay. Right. So, I mean, yes, that is the basis, but isn't there something a little more accurately? What do you mean poor flow? What do you mean high detrusor pressure? Do you use, how do you really confirm this? In other words, what are the urodynamic criteria you use?
So I can use the Abraham-Griffith curve, sir. So if it is more than 40, it is likely obstructed system in this case.
Yeah. So how do you arrive at that figure 40?
We
Measure.
need to measure the p-det at Qmax and the Qmax values.
All right.
I'm not
And
100% sure, so that's
okay. Yeah. So basically, yeah, you're right. It's p-det at Qmax minus twice the. Okay. So we'll discuss that later, right? So, all right, you do that, and if the value is more than 40, what does that tell you?
that is the patient is having obstruction, blood outflow obstruction.
Okay, and if you think this guy is 350 cc residual, you think this is underactive bladder, what do you think the value would be there?
The patient might have underactive element as well.
Yeah, so in that case, what is the value you'll expect the blood outflow index to be?
So it should be between 20 to 40.
Okay,
Not 100% sure.
right.
So less than 20 not obstructed, 20 to 40 equivocal, 40 obstructed.
Okay, right. On simple urine flow rate, when would you suspect that someone is obstructed?
If the Qmax is less than 12 ml per second,
Okay.
and the curve pattern.
Okay.
And the
And
volume.
what can you tell about the curve patterns? What are the curve patterns you know?
So normal curve is more or less
Okay.
bell-shaped like curve, and
Yeah.
then obstructed curve, that curve is lower down with the Qmax less than 12.
Yep.
And then there's a box curve in urethral stricture disease, prolonged plateau curve.
Okay. Yeah. Now, if a man under this guy is requesting surgical therapy, and you've done a TURP, and post-op, he's complaining of a lot of dysuria and frequency. How will you manage this now?
First of all, I would get a urine dipstick and as well as urine report and culture, and to exclude the urinary tract infection. That is one of the most common complication post this type of complaints. So first of all, exclude infection. If there is infection, I would treat it. And sometimes patient do get these symptoms without infection because of the post-operative that raw area that patients get these complications. And I would, if there is no infection, I would reassure that this will get settled with time, in a few weeks' time.
All right.
Time's up, sir.
Yeah. Okay. Okay, time's up. Yeah. I mean, yes. Again, I think your performance will get you a pass, right? But obviously, this is I'm being generous to you that you can't go for a FRCS or exit exam not knowing very basic, even urodynamics you'll have to know. You can't not know, right? Yes, I know it's a deficiency in our system. We don't teach it a lot. You don't see it a lot, but for an exam, it doesn't really matter, no, with what you see or what you do. That you have to polish up, and I don't think they'll go into very deep. We'll get Gobi's views on that, but I think you need to know very basic stuff properly, thoroughly. Gobi, can you come and give your comments, please? Yeah.
Yes. Again, this was a very good scenario. So that sir was asking about this bladder outflow obstruction index, or also known as the AG number, Abraham Griffith number. So Nishant know about that. So p-det Qmax minus 2 Qmax, and as you said, more than 40 outflow obstruction, and less than 20 number is unobstructed, and between those two is equivocal. So yes, as said, sir said that those are very important. So, and again, you have to mention about in the initial questions and ask about how will you assess. Of course, there was a we have to know this station is bladder dysfunction and female urology. Sir is not going to ask about straightforward TURP. So that is an important thing. When you go to the BPH station, they will ask about everything about that. So here they are going to ask about more about urodynamics and bladder dysfunction and things. So when he asks a question, you have to know, okay, this is going to move in this direction. So that is I think the most important thing. So this station is this. So knowing that is important. So sir was going towards the urodynamics and blood outflow obstruction index. Maybe you have to tell that this is a suspicious patient with the very significant residual urine. So I will do a urodynamic study before the surgery according to the upstream trial or something, So you have to read about the upstream trial. I think already Dr. Nishanda have shared that. So we have to mention that trial as well. But it's very nice scenario. Thank you, sir. So we can move to the fourth one. Tilina, over to you.
Yeah. So again, the next scenario once again will be done by Manjula Vijayavardhana sir, and the candidate is going to be Dr. Hilary Fernando. Over to you, sir.
Good evening, Hilary.
Good evening, sir.
Do you see my screen? Do you see my screen?
Yes, yes. Yeah.
Okay, you can read the description of the patient.
Okay, 40-year-old male was referred from A&E department. He had fallen. He had a fall from height few hours ago and sustained a D6 spinal cord injury. He is paraplegic and in spinal shock.
What will happen to this patient's lower urinary tract during the spinal shock stage?
So during the
What are your
spinal
thoughts?
shock, yeah. So during the spinal shock state, all the reflexes would be sort of diminished, and the bladder will be like filling and emptying. If the overflow incontinence sort of picture will be there, there will be no reflexes during the spinal shock.
Good. So how would you manage this?
So during that period, I'll be managing the patient with indwelling catheter.
Okay. What is more preferable, indwelling catheter or clean intermittent catheter?
Ideally, clean intermittent catheter, but this patient is having spinal cord injury and at D6 level, so he should have adequate dexterity to do that. But he won't be able to probably sit to do that. So in the initial period, up until everything is sorted, I'll manage with the indwelling catheter in the acute phase, and then think about shifting to clean intermittent catheterization when the patient is more stable, and because the spinal shock can actually go on for months. And so after the initial acute phase, then I'll think about CIC.
Okay. So there is some advantages if you can do clean intermittent, and actually the patient need not do it. So somebody else could do it. I have listed the reasons why it is better.
Yeah.
Right. So suppose finally the patient is being put on clean intermittent catheter, and now it is done 4 to 6 times. A bladder diary is maintained and times can be adjusted. So now the patient has gone home and the caretaker called you and say this CIC attempt has been difficult once and the patient is complaining of a severe headache. What could be the reason?
So this could be a autonomic dysreflexia presentation, because at about this spinal level, patients can develop autonomic dysreflexia. And the common causative factors are the distension of the bladder or the bowel. And with the difficulty of putting the CIC and the noxious stimuli from that, could give rise to this the initiation of autonomic dysreflexia. And what happens is these noxious stimuli actually leads to increased sympathetic outflow, and it causes tachycardia and hypertension and the vasoconstriction. And this is detected by the baroreceptors, and reflexly it will send a message to cause a vasodilatation and counteract the hypertension. Below the spinal injury level, these parasympathetic activities will not happen. So above the D6 level, the patient will have vasodilatation and below the D6 level or the injury level, the patient will have cold, clammy, and more vasoconstricted sympathetic.
Can you list some complications of this autonomic dysreflexia? Apart from this headache, any complications?
Yeah, this is a medical emergency, and it can give rise to convulsions and injuries and hemorrhagic strokes. And we need to act fast and identify the noxious stimuli and remove.
What is the immediate management?
So the initial step is to drain the bladder, and then sit the patient up, and if there's any tight garments or anything like that, we can remove them. And then we need to give sublingual GTN, calcium channel, fast-acting nifedipine.
You have to lower the blood pressure. Yes,
yeah.
You have to lower. Now it's 2 months after this episode. Patient is in the clinic. He has made a good recovery and he can walk, but he is having some urgency and he can pass some urine between the 2 sessions of CIC. How are you going to plan his long-term management?
So the spinal cord injury at D6 level, so it's a suprasacral sort of injury, which will have 3 main long-term effects. One is a neurogenic detrusor overactivity. Second being the detrusor sphincter dyssynergia, where the detrusor and the sphincter would simultaneously contract. So
what investigations would you perform at this stage?
So I'll do an ultrasound scan, and that will make sure that the bladder, the volumes, bladder wall thickness, and the hydronic upper tracts are normal, and the serum creatinine levels, and the urine analysis to make sure the patient is not having any infection at the moment. And I will I need to manage the bladder at a low pressure, because with this condition, the patient can have dangerously high pressures in the bladder that could be detrimental to the upper tracts and the renal function.
What are his chances of having, in fact, a dangerous bladder? Hilary, what are his chances of having a dangerous bladder? What are his chances?
He will definitely go on to develop a dangerous bladder or dangerously high pressures in the bladder with his clinical scenario in the spinal cord injury about the suprasacral spine. So I will I'll take prophylactic steps, say 5 times CIC.
Would you like to confirm this by a test? Prior to taking any interventions, would you like to confirm this?
Yeah, the confirmation would be by the urodynamic studies. The simple cystometrogram would be able to help.
Okay, so what do you expect? What would be your urodynamic question submitting this patient to the test? What is the question you will formulate?
whether the characteristic features of his clinical scenario, whether there is neurogenic detrusor overactivity, whether the sphincter or the EMG relaxation occurs at the point where the detrusor activity or the bladder contraction starts, or whether there is
okay, so there are two things. One is you want to know whether there is detrusor contractions, and you want to know whether the sphincter relaxes at the time of these contractions. Look at this picture and tell, out of these two urodynamic questions, which one has been answered?
So the first trace is the EMG trace of the sphincter, and then the detrusor, which is in pink, and the flow rate is in the bottom, and the quality control, the cough lines are there. And is this, yeah, permission to void. Now at the permission to void, even before that, there is detrusor overactivity, which is reflected on the vesical pressure line as well. And when the patient is asked to void, initially the EMG should go down, but then the detrusor pressure should go up. It does not reflect here, and the flow starts quite late once the EMG pressure gets low down. So there is demonstrable detrusor sphincter dysynergia in this case.
Fine, sir.
So I think,
sir, we will. You can ask a few more minutes. These are important questions, so we have enough.
okay, right. So Hilary's diagnosis is correct. It is detrusor sphincter dysynergia. So how would you manage? I have listed anticholinergics yeah, you add anticholinergics to the CIC. So when would you consider that his upper tracts are in danger? So I have given the value. So how would you follow up this patient?
I would follow this patient every 3 to 6 months initially, and then probably 6 months if his compliance is good. I follow up with the renal function tests and the ultrasound scan to make sure the upper tracts are not showing any signs of deterioration, and make sure he adheres to the plan of the CIC and the continuation of the anticholinergic in the.
So apart from the UFR, serum creatinine, and ultrasound scan, when would you decide to do another urodynamic study on this patient in the follow-up?
Yeah. So maybe say about 1 year or 1.5. I'm not sure, sir.
Okay. Right. Now, in spite of your treatment, upper tracts are starting to dilate. What would be your next therapeutic option?
So the CIC is obviously not helping in this instance. So he will have to have a low pressure bladder. So the other options are like to keep the low pressure bladder, like Botox injections, or
okay, so that is Botox injection. Is there any evidence for the use of Botox intravesical injection in neuropathic detrusor instability? Is there any known study which gives benefit to this group of patients?
I'm not sure, sir. There is a trial. But,
no, there has been a good paper. It's the Dignity Study Group. Several papers have appeared. That's in 2012, sometime back. That showed very high doses of Botox injections to the bladder has in fact given some improvement in improving the bladder compliance. Right. What if the patient finds difficulty with CIC when the Botox injection has actually achieved more compliance of the bladder? What is his next step? Now the CIC is getting physically difficult. What can you offer the patient?
Yeah, so I think I'll see whether the patient is actually mobile or not, whether the patient is wheelchair bound or not. And what is the functional situation with the lower limbs of this patient. The Botox injections will last for about maybe 6 to 9 months, maybe 7 months on the average, but then we'll have to repeat it. And to keep the bladder under low pressure, there are few things that if the patient is on wheelchair bound, then the options are to keep the sphincter open after the botulinum toxin therapy, then either urethral stents or external sphincter ablation. In that case, the patient will be incontinent for life and he'll have to wear a carbon catheter.
So we would consider a transurethral sphincterotomy and a condom catheter. What if the Botox injection to the bladder wall did not achieve the low pressure and the bladder capacity? Is there any alternative to that?
Yes, sir. So in that case, the option would be to augment the bladder with a clamp cystoplasty. But in this patient, it's going to be a bit risky, and I'll probably combine it with the mitrofenol diversion, which is going to need intermittent catheterization. So if intermittent catheterization is a problem, then that is going to be an issue. So the next option would be to divert, permanent urinary diversion with the ileal conduit.
Okay, Hillary, you are done well. So that brings end to the question.
Okay, so what's your feedback, sir?
I think Hillary was more confident, so he was thinking in the line of the examiner, so I could move faster. And he was versed with the management of a spinal cord injury patient and various options that needs to be taken. So I think he is 7 or low 8. He has done well.
Okay, sir. Thank you. And you were talking about the Truser leak point pressure. I think that's a really important point. And also people have to know about the ALPP, the abdominal leak point pressure, also known as a Valsalva leak point pressure. That is for a stress incontinence. And this is for a neurogenic bladder. Right. So we are moving to the sixth scenario. Tilina?
Yes. Sixth and final scenario of Uromet 14 is going to be done once again by Dr. Surendra Silva, and the candidate is going to be Dr. Monipriya Viradarachi. And over to you, sir.
Good evening, sir. Good evening. These are very simple clinical scenarios. I'm sure you can handle this well, right? These are, let's get down to this. I'm sorry I'll read it out because we can't get this computer connected to the internet. There's a bit of issue, right? This is a 45-year-old lady. Sorry, call came, yeah, okay. So this is a 45-year-old female who presents with recurrent dysuria and sterile pyuria. Her ultrasound is kidney ureter bladder is normal, and she also complains of episodic dyspareunia. Right? Now, what is your clinical assessment? how would you set about sorting this out? 45-year-old woman, recurrent dysuria, sterile pyuria, normal ultrasound with episodes of yeah.
I will quickly go through the history and examination of this patient with the chaperone. And in my history, especially, I will focus on the patient's the lower urinary tract symptoms related to the urinary tract infection. And the other thing is, I want to see whether the patient is received recurrent treatment for this symptoms. And also this patient is having sterile pyuria, so because of that, so I want to know confidentially, I want to get the history about the sexual history, because can be related to the sexual transmitted disease as well. And in gynecological history, I would focus on menstruation related history, especially the history suggestive of history of endometriosis, dysmenorrhea, like that, which can cause the chronic pelvic inflammatory diseases. And then there is an episode of dyspareunia as well. So because of that, I would look for that gynecological history mainly. And then on examination, general examination, I want to do see the especially lungs, because sterile pyuria can be due to tuberculosis, extrapulmonary tuberculosis. So any history in history also, I want to go through the pulmonary tuberculosis history. And then general appearance of the body in examination, and abdominal examination, whether I can feel palpable bladder or ballotment of the kidney, which evidence of hydronephrosis, but ultrasonically it shows normal. But then with the chaperone, again, I want to see the patient's genitalia examination, especially the vulval area and the urethral opening, and the vaginal examination to complete my examination. Any adnexial masses, any suspicious of cervical abnormalities or cervical malignancies, like that.
Okay. Muni, now on this patient, how would you set about doing the vaginal examination, and where will you be focusing on? What area will you be most interested in here now in solving her symptoms?
Yeah, in vaginal examination, especially, I want to look for whether the patient is having anterior vaginal wall defect, that is cystocele, or any organ prolapse. So,
right. Is there anything else? No, I will tell you, there's no cystocele and no organ prolapse.
Other thing is the paraurethral cyst or paraurethral diverticula. I want to exclude, sir.
Yeah, there is a little bit of fullness just inside the introitus, just beyond the introitus. There's a little fullness there. Yeah, it's bulging. Yeah. Yeah.
So it could be a paraurethral diverticuli, sir, and usually the urethral diverticuli occurs in proximal two-thirds, and we can visualize the opening in the within the proximal two-thirds, but we can feel small lump-like masses in the anterior vaginal wall closer to the urethra.
So now, how would you think she's got something there in the anterior vaginal wall? Now, how do you set about making the diagnosis?
In this situation, I would explain the patient, and I would get the consent for the examination, especially the cystoscopic examination.
And how and what are you going to concentrate on this cystoscopy? What are the important things you're going to concentrate here?
in cystoscopy, I want to see the urethra, then the any abnormal opening while I straighten the urethra by finger direction of the anterior vaginal wall. So sometimes I can miss the urethral opening in the diverticuli. Then other thing is I want to see the bladder, interior view of the bladder, any features of infection or any suspicious cause for malignancy or any other condition in the bladder.
Yeah, you do the cystoscopy. The bladder is pristine clear. There's nothing. There's nothing at all in the bladder. Mucosa is good. The urine looks absolutely clear, right, to the naked eye. No debris at all.
Yes. Then if I couldn't find any abnormalities, to confirm any other possibilities like interstitial cystitis or the interstitial cystitis like features, I would go for a random bladder biopsy to histological confirmation of the interstitial cystitis like features.
Now, what about that little lump you felt in the anterior, just deep to the introitus, just beyond that? Now,
with the digital, while I withdraw in the cystoscope, I will compress that lump and see whether any substance coming through that opening, if there is an opening, that would show the possibility of the paraurethral cyst, because purulent discharge or blood stain discharge can come when we compress the cyst.
Yeah, it's not very clear. That area looks a little abnormal, very erythematous, but can't really express anything. Yeah.
In that case, next investigation would be the voiding cystometrogram, because sometimes in voiding cystometrogram, the contrast will fill into that area and we can visualize the paraurethral cyst. But in gold standard management, the gold standard investigation would be the MRI. So that is the lineup in my investigations.
Yeah. So we'll assume your cystogram shows a little dip there, like a little beak, and yes, she has money. She goes to Colombo and gets an MRI done, and yes, there's a diverticulum there. Now what do you do?
I will explain the patient and I would offer her surgery. So my surgery would be under spinal anesthesia or the general anesthesia. So I would position the patient lithotomy position and the speculum examination, and I would do the incision, inverted U-shape incision over the anterior vaginal wall and carefully dissect around the cyst, and then I will try to find out the stalk and take the urethral cyst, paraurethral cyst excision, and repair the urethra. During this procedure, I make sure I won't do any damage to the urethra by putting the catheter initially.
Yeah.
And after excision and repair of the urethral site, then I want to get fat pedicle, the vascular fat pedicle in between the urethra and the vaginal wall, and then I will close the vagina without any dead space in between that area and the vagina, and vaginal suturing would be using the 4-knot polygalactine to absorbable sutures, and after that I will put a vaginal pack, and after 24 hours I would make sure the vaginal pack is removed, and in 3 days
3 to 4 days time, I would remove the catheter as well.
Okay. Yeah. Okay. Yes. I mean, he did it really well. I would have, yeah, I think he did it really well. I would have liked if he just said before he operated, he puts the catheter, right? That's all, right? That's all, if at all, I had to correct, but otherwise, done very well. Yeah, excellent.
Thank you, sir.
Yeah, so I think we have covered urethral diverticulum, and other possibilities they will ask is bladder pain syndrome, isn't it, sir?
Yeah.
Or interstitial cystitis, and we have covered the neurogenic bladder. Maybe they will ask a scenario like prostate cancer or something with coda equina, just to work out the infrasacral lesion. And yeah, I think we have covered the most of the scenarios that's come with the female urology and neurourology. So any question you want to ask, the candidates can ask a question from, it was excellent questions from Suren sir and Manjula sir. Very nice, nicely made scenarios. Any question you want to ask?
Tahi, I would just like to know what is the rest of the question Manjula sir wanted me to ask for VVF repair. I mean,
Shall I show you this? Yeah, shall I show you the slides?
Yes, sir. Yeah.
Okay. You see my slide? Huh?
Yeah.
Do you see? Okay. So next question was this. Patient is well, there is no sepsis and infection. So how would you proceed, evaluating this patient? I was expecting these answers. Are you there, Taha?
Yes, sir.
Are you there?
Yes, sir.
So you can answer from here. So I'll show you the next slide. Now that is the view of the cystoscopy. To make it clear, near the right ureteric orifice there is a bit of a scar, but no definite fistular struct can be seen.
Okay, sir.
So anything you do to confirm vesicovaginal fistula at this time of the cystoscopic EUA?
Yeah, I can do intubation of that VVF hole with a pterymo guide wire softened, and I can see whether it's a pterymo in this coming through the vagina, or else
what is a less invasive one?
I can fill the bladder with methylene blue and then see whether there is any discharge or the methylene blue.
What do you call this test? What do you call this test?
T-swabs test.
3 stops, very good. Right. So do you know of any classification for VVF?
I'm not sure about that. Sorry.
Yeah, there are very little literature on VVF, so classifications are not that developed.
Okay, sir.
Either you classify it as simple or complex, or go by the size.
Okay.
Less than 5 millimeter is small, more than 25 millimeter is large. Anything is in between is intermediate.
Okay.
Okay. So when are you planning to repair this? What is your timing? What is the timing from the time of injury?
Okay. So normally,
what is your experience?
It all depends on the institutional and the person or surgeon's policy. Normally, what they recommend is 3 months. We have to wait for 3 months where the inflammation and the hematoma settle down.
Okay, if you are planning if you are planning a bladder indwelling catheter and conservative management, when would you give up?
So recent papers, they have suggested early repair would be beneficial. So at least probably like 6 to 8 weeks time, we may offer her repair.
Do you know of any endoscopic management of a VVF?
Yeah, there are. If the size is less than 5 millimeter and if the pattern is like zigzag pattern, then we can offer endoscopic laser ablation, which can treat the VVF, but all depend on the size and the place of the VVF.
Okay, well, how would you decide on your surgical approach? Vaginal or abdomen, how would you decide?
It again depends on the surgeon's experience as well as the facilities available at the institution, for example, and the space and the site of the vesicovaginal fistula. If it is lower down, vesicovaginal fistula is better. And the other thing is patient's previous factors like radiotherapy, because poor wound healing, because these needs interrupted or omental interruption or pedicule. So that needs abdominal repair. So all depends on these factors.
Right. What are the vascularized pedicles you would use if you are going transabdominally?
Transabdominal, I can take omental flap, which is the great omentum. I can bring it down between the vagina and the bladder, which has more blood supply. Or else, if it is a vaginal exploration, I can take Martius flap, which is a labia majora, fat pad, long flap, which has good blood supply from 3 sides, I think, inferior labial. And
I was also thinking of a peritoneal flap. So from the abdominal side, if your omentum cannot be dragged that much down or lengthened, you can use a peritoneal patch.
Okay, sir.
Right. So at the end of the operation, what would be a post-op management? Catheter for how long? Indwelling catheter after the operation?
Ideally, I would keep the catheter for 2 weeks, but again, before removal, I can do a periurethral pericatheter cystogram to confirm there's no leakage. If there's no leakage, I can remove the catheter in 2 weeks' time.
Right. Suppose a patient has wetted the bed sheet after the operation. How long will you manage without an intervention to know whether this is actually a failed repair?
I can wait for, normal wound healing takes about 4 to 6 weeks time. I can wait for 4 to 6 weeks time, but again, depends on the amount of the leakage. If it is just a few drops, I can wait, but if it is pouring like early, if I go in early, I can see the defect and repair, because if it is late, the dissection will be more difficult.
Suppose the patient wants to have sexual relationships, so sexual activity, when would you advise a patient to have it? And my answer has appeared. Okay. So what is the broad success rates you have for this VVF repairs?
I'm quite not sure, sir.
Okay, depends on whether it is a simple or complex. So it can be 100% to 60%, and these are some of the complications that are listed.
Okay, sir.
So that is the end of that question.
Okay, thank you, sir.
Thank you very much, sir. And a few more things. So we have to add. So we have to know everything about the bladder diary. And of course, they ask that difference between bladder diary and frequency chart. So which one is give more information? I think I can discuss with someone, so I can. Nishandan? Nishandan is here.
I can answer, Gobi, if no one is there.
Yeah. So if someone asks what are the additional informations included in the bladder diary when compared to the just a frequency volume chart?
So frequency volume chart is just the volume of the intake and the frequency of urination with incontinence, whereas the bladder diary will be telling us the type, volume of the fluid intake, and the urine, the amount, timing as if there any leakage with the, the severity of the leakage, sometime with the amount of pads.
Yeah, so more information from bladder diary. And Taha, in a idiopathic diffuse overactivity, if you are going for a Botox,
yeah,
how many units they give? If you are using for a neurogenic diffuse overactivity, how many units they give Botox?
So in idiopathic, the normal dose is 200, but again, if the patient is high risk of post-operative retention, we'll always give with 100 units. Whereas in neuropathic diffuse overactivity, we'll go with 200 unit, and this Dignity trial has shown there's no difference between 300 and 200. So we'll start with 200.
Yeah. So IDO 100 units, NDO 200 units. That's a correct answer. Yeah. Now, what do you understand by 1 unit of Botox? Same question they asked me, so I'm asking again. So how they label this is a 1 unit of Botox. So during that time, I didn't know the answer again. So what is 1 unit of Botox says? LD50. LD50 mean to kill a 1 rat. What is the medium lethal dose of Botox? So they inject the Botox into the peritoneal cavity of the rat. So what is the median value of the Botox? That is a 1 unit. So 1 unit of Botox means that is enough to kill a rat. LD50, lethal dose of median lethal dose. So that is a 1 unit of Botox. So they might ask, what do you understand by 1 unit of Botox? Now, what are the different preparation of botulinum toxin is available in the market, Taha?
Botox is a brand of US brand, and the Dysport is UK brand. Botox is 5 times potent than the Dysport. And there's a German product also, which I can't remember the name.
So do you think the units are same when you use a different preparation? Is it units are same or different?
As I said, Botox is 5 times potent. So if we use Dysport, it should be like for 200 units of Botox, we should use 1,000 units of Dysport.
Yeah, the things we had know is a different unit. So we can't just say 100 units for everything. Yeah. Now, what is the mechanism of action of botulinum toxin? How it's working in the overactive bladder?
So it temporarily blocks the presynaptic vesicular release of acetylcholine by releasing or distracting the SNAP25 protein complex from SNAP protein. So the acetylcholine needed for diffuser contraction.
Yeah. So just remember that name, SNAP25 and SNAP protein. Yeah, neuromuscular junction of parasympathetic nerve. So the junction between postsynaptic parasympathetic nerve and the detrusor muscle. That junction, it stops the release of acetylcholine. So what are the contraindications for to give the botulinum toxin? So you can give in anyone or any contraindication?
So it's like myasthenia gravis,
Okay.
active inflammatory bowel disease, neuromuscular glaucoma.
No,
and,
that is active glaucoma. It's for anticholinergic, solifenacin and oxybutynin, acute glaucoma.
Messed up, I think.
So this one, acute UTI. So that's why you had to do a urine culture before giving Botox, and you had to do a beta ICG urine because pregnancy is a contraindication, and the acute UTI is a contraindication.
And peripheral myopathy. Peripheral myopathy is any new active neurological disease.
Yes, sir. Yeah. So those are the contraindications. And before giving the Botox, you have to tell the patient and you have to prepare the patient for one thing. What is that?
Self-catheterization.
Sorry?
Counsel for self-catheterization?
Very good. So what is the incidence of acute retention of urine after the botulinum toxin?
About 50%.
10%, yeah. 10%. So suppose you give Botox for idiopathic diffuse overactivity, what is the response rate?
So response rate is 50 to 70%, but its mean period would be 6 months time.
Excellent. So 50% reduction in the urge incontinence and 25% become completely dry. And as you said, the response will say for 6 months, medium, six to 9 months. So you have to repeat the Botox again. So how many times you can repeat this?
I think can be repeated 8 times if I'm not pretty sure.
Repeat any time. So it's not an issue. Now, where are you going to give the injection? What point of the bladder?
So we should avoid ureteric orifice and trigone. It can be diluted. 200 units we can dilute it into 20 millimeter in 20 or 10 stage and then positions. 2 millimeter deep and 1 centimeter apart.
Right. So
sorry about that.
Supratrigonal and into the detrusor muscle. So will you add methylene blue just to confirm there's a good bulging and you are correctly entering into the detrusor? Can you mix the methylene blue with your Botox, or what do you think? Of course, that is not recommended. That's the question I want. Yeah, they say not to recommend. Some people mix a methylene blue and inject just to show that it's entering into the. You can't see when you are injecting whether it's really going into that or going somewhere else. So you don't know. Right now, okay. Now the Botox is more effective in neurogenic detrusor overactivity or idiopathic detrusor overactivity.
It is more effective in neurogenic, but it takes more time, like 9 to 10 months.
Okay, so we already discussed in IDO, 50% reduction in the urge incontinence and 25% become dry. What about in NDO?
NDO, it's around 90%.
Yeah, 2/3 become 2/3 reduction of urge incontinence and 1/3 become dry. So it's more in neurogenic detrusor overactivity when compared to the IDO. Right. So we discussed that. Now, Taha, is it safe to give oxybutynin and solifenacin in elderly people? Any concern?
So these are the anticholinergic which can cause cognitive dysfunction. The paper from Seattle has shown, followed up cohort of patient for 10 years, which has shown there is an association between anticholinergic and cognitive impairment. It is dose dependent. It's not dependent on the time of usage of the drug, but all depend on the type of the anticholinergic, whether it is quaternary or tertiary amine, and whether it is
suppose you are getting a 40-year-old lady with overactive bladder, and you are going to start the oxybutynin, and she has read the paper, and she is asking, doctor, will it cause dementia? So how are you going to counsel her?
There is it is not a causative factor, it is associated. So all depends on the type of the and dose of the anticholinergics, where I would prefer selective, such as solifenacin or darifenacin, and I would omit tertiary amines like oxybutynin, which may cause more symptoms.
Yeah, you can say this risk is only a slight risk, 1.5 times risk, and it's all depending on, as you said, anticholinergic load rather than just one tablet. If people are more anticholinergic, they have a more risk. Yes, you said it right. Now, if Botox also failed, any other option we have?
So after that, we can go for sacral neuromodulation or PTNS, posterior tibial neuromodulation, and there's other option for augmentation cystoplasty.
So regarding the sacral nerve modulation, so they effectively fix the sacral modulator, or they will fix for a temporary basis and see what they do.
It's a 2-stage procedure which can be done under local or general anesthesia. So initially we go for temporary pulse generator with a 3-segment electrode. Then we wait for 2 weeks time, sorry. And if there is more than 50% response in the bladder diary, we'll go for permanent implantation of the
so how is the cost-wise device is how much? Is it possible to do it here?
Not quite sure.
Yeah, around 5,000 pounds. Yeah, so it's expensive. Now, which nerve root or which foramina they put the electrode?
S3.
So while you have placed that during the placement, how will you check that is it really working?
So it's like a plantarflexion of toes and fanning out of veins, so that oral's anal bellows.
Yeah,
So we
patient will feel that there's a pulling sensation in the anus and the vagina. So basically, yeah, S3 myotome and S3 dermatome. Yes, so they will ask about things. Do you know about Fowler syndrome, Taha? You heard about Fowler syndrome?
Fowler syndrome is a primary dysfunction of sphincter relaxation. Usually occurs in young female like 30 to 40. So it's a sudden onset of retention because of failure of relaxation. The EMG would be EMG would show there is continuous contraction of the sphincters.
Okay, so basically it's kind of our external sphincter discoordination.
Option for them would be sacral stimulation.
Yeah, so that's it's a very good response with the sacral nerve stimulation. So that is the thing we have to know, right? So we discuss about augmentation cystoplasty today, Daha. Now, so how they do it? Is it they cut the bladder in horizontal plane or vertical plane, or what plane they coronal plane or sagittal plane? How they cut the bladder?
So it's like a clam cystoplasty. We are making the bladder into a clam. So it's like from left to right. And then we augment the bladder with intestine, mostly with ileum. So we will increase the bladder compliance and reduce the contraction and reduce the pressure.
Okay, will you do this procedure in someone who have a EGFR of less than 15 or very low EGFR? Will you do this procedure?
So we are attaching the bowel segment to the bladder. So there's absorption of ammonia, which may not be handled by renal, because so patient with low renal function, mainly GFR is less than 15, there is a risk of renal deterioration.
Okay, what is the metabolic problem they will develop?
Hyperchloremic, hypokalemic metabolic acidosis.
Yeah, and you talk about ammonia. So in what kind of people, one contraindication for this kind of neobladder and things is renal failure. What is the other failure we have to?
So liver failure also, they may not be able to handle this ammonium. So
ammonia. So we can develop
liver,
encephalopathy, isn't it?
yes.
Now suppose in a last resort in this kind of incontinence is urinary diversion.
Yes.
So when you divert, maybe you can do ileal conduit or something. Can you leave the bladder in ileal conduit without removing? Wait, suppose a patient is coming, not fit for major surgery, lot of fibrosis in the pelvis. If you just leave the bladder in the pelvis without removing, just you are doing a diversion with ileal conduit. So what is the worry? What can happen? Is it okay to do that?
So some fibrosis, I think, I'm not sure.
So yeah, so it's not good because they can develop collection of mucus and can get infected. That is known as pyocystitis. Yeah, Sir has said pyocystitis or vesical empyema. So that is not recommended. And today, Sir said about diffuser leak point pressure, and you must have read about Valsalva leak point pressure, VLPP.
Yeah.
So if VLPP is less than 60, what is the reason for the stress incontinence?
So, but Valsalva leak point pressure is the lowest intravesical pressure where there is urine leakage without due to the presence of abdominal due to increased abdominal pressure with the absence of detrusor contraction. If it is less than 60, it should be like more possibility of intrinsic the sphincter deficiency. Where it is more than 90, it should be urethral hypermobility. Between 60 to 90, it is equivocal, and if it is more than 150,
yeah. So in this era, so we are reluctant to use the synthetic tapes. for the stress incontinence. So what we can use instead of synthetic tapes?
So we can use autologous slings such as fasciolata or rectus sheath.
Okay. Now, today we discussed that for a stress urinary incontinence, video urodynamic is better. So you can. So what is what we are looking in that in video urodynamics in stress in urinary incontinence?
So there will be dilatation of the posterior urethra and hold up at the sphincter while the detrusor is contracting. So synchronous.
So we are looking the bladder neck position related to what? What is the sorry?
Pelvic flow or scale tuberosity?
The inferior border of the pubic symphysis. So that is a landmark, right? If it is coming below that, more than 2 centimeter. So yeah, so Dr. Nishant have answered. I am asking next question, what is that classification? So the Blyver's classification. So Blyver's classification of bladder neck and the stress incontinence is based on the video cystometry, the position of bladder neck and the IMPS. IMPS is the inferior margin of the pubic symphysis. So 1 to 4, so 1 to 3. So we have to know that Blyver's classification. Yes. Taha, do we use a vaginal grip test to assess the pelvic flow? Is it recommended in the NICE guideline or PAU guideline?
Only the pad test is recommended, not this vaginal grip test, not recommended.
Yeah, in the NICE, they have recommended the vaginal grip test, not in the EAU. NICE, they have recommended. So it's also known as Oxford grading of pelvic floor muscle. So that we have to mention. And regard to the pelvic organ prolapse, Taha, do you know any classification for a pelvic organ prolapse? Like Blyver's classification for stress urinary incontinence, bladder neck position. Any other staging or classification system you know for a pelvic organ prolapse?
There are 2 systems. One is ICS POPS classification, so it is 2 at Hyman level. One is between 2 and 0, approximate -2. One is above -2. That is ICS. 4 is.
Yeah, that is POPQ system, isn't it?
Yes.
Pelvic organ prolapse quantification system, POPQ system that you are mentioning about minus and. So there's another one that just a, if it is, so what is a landmark from where they compare?
Hyman,
like in Blyver's, the landmark is the inferior margin of pubic symphysis. In a POP, what is the landmark?
Hyman.
Yeah, very good. So introitus or Hyman. So other one like POPQ is the standard one, but very complex, difficult to understand. The easy one is Baden and Walker. Baden and Walker. Yeah, 0, 1, 2, 3, 4. Baden and Walker. So the 4 is known as a Presidencia. Everything, right? I think, yeah, that's all I want to give the input. Sorry to trouble you.
No problem. Thank you.
Yeah. So any other question? And Ananda sir is here. Sir, your feedback, please, sir. Ananda sir? Any other question you want to ask by other people?
Obi, I could not hear about it. Sorry about that. About this methylene glue, should we use it or is it not recommended?
Not recommended. We don't have any. I don't know that they have a study, but they not recommending because they think they say no. Don't shake the bottle also. The bottle and toxin, Botox bottle, never to shake.
Okay.
Because and also they say not to add the methylene glue also. Yeah.
Okay. Thank you, Yogi.
Yeah. Thank you. Any other question?
And not to give gentamicin also, no, as antibiotic, aminoglycoside.
Yeah, so they are saying not to give a gentamicin because pharmacokinetics, there's interaction. But if you see in UCL, University College of London, they are not recommending gentamicin, but in the Guy's Hospital, they are using the gentamicin. So again, it's a controversy, but yeah, they're saying theoretically it's not to mix, give gentamicin in a patient getting a Botox. Yeah.
Kobe, augmentation cystoplasty, you divide the bladder from posterior to anterior, no? Not from right to left.
But sir, I have never done, sir, but the book says in the coronal plane, sir.
Yeah, so posterior to anterior, not from left to right.
Sir, the book says it's the coronal plane, sir. So it's the
So
right
coronal
one.
is anterior to posterior, no?
No, sir.
Anterior to
That is
posterior.
posterior, sir.
I don't know. We did one 2 weeks ago and we did like that. That's right.
Yes, usually we do the anterior to posterior from the supratrigonal area to anterior bladder neck.
That's right. That's right. Because
otherwise, yeah.
blood supply.
No, otherwise you are violating the vesical blood supply.
Yeah, yeah.
The front half will not have a blood supply.
Yes.
So if you split in the middle, the two sides vesical artery complexes will manage.
That's right. Yeah. Okay, thanks. Thank you.
And Dr. Sarisan have asked question that what is the evidence for diffuser leak point pressure 40 and the upper tract? I don't know the exact evidence, but that is the, in follow-up for a neurogenic bladder, they asked to do a ultrasound scan to check the upper tract, and they asked to do a renal function and check the blood pressure and check the diffuser leak point pressure. If it is more than 40, that's mean it's a high pressure system that can cause upper tract dilatation. But I don't know the exact. But it's a well documented things. A DLPP more than 40, but I don't know the evidence. Yeah. Any other questions? Okay, Selina, over to you. We can conclude the session today. And the next session will be on next Saturday on prostate cancer, is oncology 1. So prostate cancer and the penile and the testicular cancer, which will be done by Professor Srinath and Dr. Ranga Vikramasra. Yeah, Selina, over to you.
Right. So that brings us to the end of this very interesting Viva session on female urology. Let me thank all the candidates, the volunteers, as well as Dr. Suren De Silva and Dr. Manjula Vijayavardhana for the excellent case scenarios. I think all of us benefited significantly, and that gave us a good taste of what we can expect during the exam. So thank you very much, everyone. And as usual, Dr. Balagopi and Anuruddha sir for their valuable inputs. So we'll meet again, I think, next time in the we'll meet again next time. I think before the next Viva session, it will be again, there will be another clinical trials discussion. And afterwards, next Saturday, we'll have the Viva session again. So good night, everyone. And thank you for joining.
Thank you.
Good night.
Thank you.
Thank you very much, sir. Good night.